Welcome to PRISM Rounds, the audio journal club where we break down one study at a time for ICU, ED, and pulmonary/critical care teams, physicians, trainees, nurses, pharmacists, and respiratory therapists. A quick note before we start, this episode is created using AI-generated voices. I originally made these episodes to support my own learning and review, and I'm sharing them publicly in case they're helpful to other busy clinicians and learners. Because the voices are synthetic, you may occasionally hear mispronunciations of medical terms, drug names, or author names. Thanks in advance for your patience. Everything you'll hear is for education only and not medical advice. Let's get into today's paper.
Usually when you reach into your toolbox to fix a leaky pipe, you just grab the biggest, heaviest wrench you can find.
Right. You just want the leak to stop.
Exactly. You want maximum torque, and you want it to stop immediately. But imagine if that wrench was so aggressive, so unwieldy, that the sheer force of using it could randomly puncture the pipe somewhere else.
Right, while you're still trying to fix the first leak.
Yeah. Suddenly, you're not just looking for the strongest tool anymore.
Right.
I mean, you need the one that balances stopping the initial problem without creating a brand new, potentially worse emergency.
Which is, the fundamental tension in anticoagulation therapy, especially in the ICU.
Oh, absolutely.
You're deliberately impairing the body's ability to form clots to treat a life-threatening blockage. But in doing so, you're actively increasing the risk of a catastrophic bleed somewhere else in the system.
And that tightrope walk is what we face every single day at the bedside when treating acute venous thromboembolism, or VTE.
Yeah, it's a constant balancing act.
Welcome to this PRISM Rounds deep dive. I'm thrilled you could join us today because right out of the gate, we have a massive shift in how we understand the tools used for this job.
A really massive shift.
Here's the bottom line for you right up front. For most patients dealing with acute VTE, a brand new randomized trial suggests the blood thinner Apixaban is safer than Rivaroxaban.
Considerably safer.
Showing significantly less bleeding with no obvious loss of effectiveness over a 3-month period.
Yeah, we are looking at practice-changing data here. I mean, for years, clinicians have basically been forced to guess which of these two frontline therapies offered the better safety profile.
Total guesswork. Our mission today is to help you, whether you're a fellow medical professional updating your clinical algorithms or just, an insanely curious learner fascinated by how evidence-based medicine actually evolves. We want to help you understand exactly why this shifts the landscape.
It's going to change how we write orders, no question.
We are pulling from a stack of incredibly fresh, high-impact sources today. We've got the March 2026 NEJM COBRRA trial, the accompanying NEJM editorial, and just to set the stage, a highly contextual July 2025 JMA Internal Medicine observational study.
It's a great lineup of papers.
Okay, let's unpack this, because to really grasp the weight of this new trial, we should probably look at the rather murky pre-trial landscape we were dealing with.
Yeah, it was murky for sure. For the last decade or so, direct oral anticoagulants, the DOACs, have largely dominated this space. They essentially push warfarin right to the sidelines for standard VTE treatment.
Which totally makes sense. I mean, warfarin is notoriously difficult to manage.
Oh, it's a nightmare.
We have dietary restrictions, constant INR monitoring, and just an incredibly narrow therapeutic window.
Right. The DOACs offered a fixed-dose alternative that freed patients from all that continuous monitoring. And, they offered a generally superior safety profile.
Once we settled into the DOAC era, a new problem emerged on service.
We ended up with this frustrating safety toss-up. Apixaban and Rivaroxaban quickly became the two leading DOACs globally, and both had been rigorously tested against warfarin in their own landmark trials.
And they performed beautifully against warfarin.
They did, but remarkably, they had never been tested head-to-head against each other in a large randomized controlled trial for acute VTE.
It's wild to think about.
It is. Clinicians were just looking at indirect comparisons, trying to extrapolate which one was actually safer for the specific patient sitting right in front of them.
Which brings us to the breadcrumbs that led up to this moment. Before we get to the new randomized beta, we have to look at that July 2025 JMA Internal Medicine study.
The big observational one.
Yeah, this was observational, but the sheer scale of it is what caught everyone's attention. We are talking about a massive, real-world cohort of over 163,000 patients.
Yeah, pulling from all those extensive insurance and Medicare databases, the sample size was just monumental.
Huge.
And the researchers weren't just looking at raw outcomes. They used sophisticated propensity score matching.
So trying to balance the scales, essentially.
Exactly. They basically tried to create synthetic twins. So matching a patient on Apixaban with a nearly identical patient on Rivaroxaban based on dozens of clinical variables, comorbidities, demographic factors, just trying to isolate the effect of the drug itself.
And the signal they found was incredibly strong. The data showed that patients taking Apixaban had a lower risk of recurrent VTE with a hazard ratio of 0.87 compared to Rivaroxaban.
Right.
But the safety data was the real headline there. Apixaban showed a 31% lower risk of major bleeding. That's a hazard ratio of burn 0.69.
I mean, seeing a hazard ratio of 0.69 for major bleeding in a cohort of over 160,000 propensity-matched patients, that's the kind of finding that immediately makes you sit up and pay attention.
I look at a number like 163,000 patients, and part of me thinks, well, why wasn't that enough?
It seems like it should be.
Right. If you have a study that massive showing Apixaban is safer, why didn't the medical community just declare a winner right then and there?
Because of the flaws inherent in observational data.
Exactly. Comparing observational data, even with all that fancy propensity matching, it feels a bit like trying to determine which of two athletes is faster by timing them on different days, on different tracks, in entirely different weather conditions.
That is a perfect analogy.
You can use all the math in the world to adjust for the wind speed and the track surface, and you'll get a very good hint of who might be faster. But you can't be scientifically certain until you put them on the exact same starting line, at the exact same time, and fire the gun.
And that athlete analogy perfectly captures the danger of residual confounding.
Right.
Because in any retrospective database, you are looking at decisions that were actively made by a physician in the real world. Why did Dr. A choose Apixaban while Dr. B chose Rivaroxaban?
You don't know the thought process.
You don't. Even with 163,000 patients, you cannot fully account for the unmeasured variables. Perhaps there was a subconscious clinical bias where doctors reserved Apixaban for their frailest, highest bleeding risk patients because of an unspoken clinical hunch.
Or maybe local insurance formularies pushed healthier patients toward one drug over the other. You just can't code for a doctor's gut feeling when they look at a patient in the exam room.
You really can't. And that residual confounding means observational data can only generate a hypothesis. It cannot prove causality. To change clinical practice guidelines, you have to eliminate that selection bias entirely.
Which means you have to randomize. And that is the perfect pivot to the main event here, the NEJM COBRRA trial.
Yes, the big one.
Which stands for Comparison of Bleeding Risk between Rivaroxaban and Apixaban. This was a pragmatic international PROBRCT.
The design is really interesting.
Let's break down that PROB acronym, actually, because the trial design here is quite elegant. It stands for Prospective, Randomized, Open-Label, Blinded Endpoint.
It's a design that really balances scientific rigor with real-world applicability. You know, in a classic double-blind trial, neither the patient nor the doctor knows what drug is being taken. But because Apixaban and Rivaroxaban have entirely different dosing schedules, running a true double-blind trial would have been a logistical nightmare.
You'd have to give patients a complex array of demi-pills just to match the dosing frequencies, which, doesn't reflect how they would actually take the medication in their normal lives at all.
Precisely. So the PRAB design allows the treatment to be open label, meaning the patients and their treating physicians know exactly which drug they are taking.
Which mimics real-world adherence and behavior.
Exactly. But the blinded endpoint part is the crucial safeguard here. The independent committee that actually reviews the medical charts to determine if a bleeding event or a recurrent clot occurred, they have no idea which drug the patient was assigned to.
It's brilliant. It strips the bias out of the interpretation of the results while keeping the actual treatment phase totally grounded in reality.
It really is the best of both worlds.
So the investigators randomized 2,760 patients presenting with symptomatic pulmonary embolism or proximal deep vein thrombosis. And this is where we really need to focus on those dosing regimens you mentioned earlier.
Yes, because they diverge sharply right from day one.
The standard protocols for these drugs are very different. The Apixaban group received a high-loading dose of 10 milligrams twice daily for just 7 days, before stepping down to a maintenance dose of 5 milligrams twice daily.
So just 1 week of the intense loading phase.
Right. Contrast that with the Rivaroxaban group. They received a high-loading dose of 15 milligrams twice daily for a full 21 days before dropping down to a maintenance dose of 20 milligrams taken once daily.
Keep those specific timelines and daily frequencies in mind, everyone. 7 days versus 21 days for the loading phase, and twice daily versus once daily for the maintenance phase.
It's going to be very important later. Let's look at what actually happened over the 3 months of the trial period. The primary safety outcomes were striking.
Very striking.
For clinically relevant bleeding, the rate was 3.3% for patients on Apixaban versus 7.1% for patients on Rivaroxaban.
Wow.
That gives us a relative risk of 0.46.
A relative risk of 0.46 means the Apixaban group experienced less than half the bleeding events of the Rivaroxaban group.
Less than half.
Yeah. I mean, in the context of anticoagulation, cutting a major side effect by more than 50% is a profound clinical victory.
It gets even more pronounced when you isolate just the major bleeding events, the highly dangerous, potentially life-threatening bleeds that land people in our ICU.
The ones we really worry about.
Major bleeding occurred in only 0.4% of the Apixaban group versus 2.4% of the Rivaroxaban group. That's a relative risk of 0.16.
That is massive.
And even if we look at clinically relevant non-major bleeding, Apixaban was still significantly safer at 2.9% versus 4.9%, a relative risk of 0.59. Across every single category of bleeding, Apixaban demonstrated a clear, undeniable advantage.
But, safety is only half the equation here. A blood thinner that doesn't cause bleeding is completely useless if it also fails to prevent blood clots.
Exactly. We can't just trade one problem for another.
Right. We have to look at the efficacy data to ensure we aren't just trading bleeding risk for clotting risk.
So looking at the recurrent symptomatic VTE rates, the numbers were incredibly tight. It was 1.1% for patients on Apixaban compared to 1.0% on Rivaroxaban.
Basically identical.
Yeah, that's a relative risk of 1.08. On the surface, those numbers look practically the same. But there is a statistical caveat here that the trial authors are very transparent about.
Right. The caveat lies in the confidence intervals. Because recurrent VTE events were so remarkably rare in this trial, hovering right around 1% for both groups, the statistical power of the study shifts.
It's hard to measure something that almost never happens.
Exactly. When you are looking for a difference in an event that hardly ever happens, you need an astronomically large sample size to definitively prove non-inferiority from a strict mathematical standpoint.
So while the 2,760 patients were more than enough to clearly prove the bleeding difference, because bleeding happened frequently enough to generate robust statistics, it wasn't quite a large enough cohort to say with absolute mathematical certainty that the two drugs are perfectly 100% equivalent in preventing clots.
That is the crucial distinction here. The trial did not show any signal whatsoever of diminished efficacy with Apixaban. I mean, it clearly worked incredibly well.
Yeah, 1.1% is a great outcome.
It is, but methodologically, we have to view this primarily as a bleeding trial that strongly suggests equal efficacy rather than a definitively powered efficacy equivalence trial.
Okay, so the RCT has done its job. It confirmed the signal from the observational JAMA study and definitively answered the safety question.
Yes.
The accompanying NEJM editorial even goes so far as to officially call an end to the safety toss-up based on this data.
Which is a bold statement, but backed by the numbers.
But as a reader and as a doctor, that immediately leaves me with a glaring biological mystery. If Apixaban and Rivaroxaban are both DOACs, they both target factor XA in the coagulation cascade, why on earth does one cause so much more bleeding than the other?
That is where the NEJM editorial provides some phenomenal insight. The authors zero in on two primary biological mechanisms that likely drive this disparity. And, both of them trace directly back to those dosing regimens we highlighted earlier.
The loading phase. I'm looking at the loading dose duration first. Rivaroxaban pushes that high-intensity phase for 21 days, whereas Apixaban drops down after just 7.
Right.
It stands to reason that keeping a patient's coagulation system suppressed at maximum intensity for an extra 2 weeks is inherently going to drive up the bleeding risk.
And the trial data visually confirms your logic there. When you look at the Kaplan-Meier curves, the graphs that plot the cumulative incidence of bleeding events over time, the lines for Apixaban and Rivaroxaban separate sharply and early.
Right at the beginning.
Exactly. Most of that divergence happens during those initial 21 days. The editorial strongly argues that Rivaroxaban's extended 14 days of high-intensity therapy essentially front-loads a massive bleeding burden onto the patient.
Without offering any corresponding reduction in early clot recurrence, you are taking on 2 extra weeks of maximum risk without any extra reward.
Exactly.
That alone seems like a sufficient explanation, honestly. But the editorial also points to the maintenance phase. Once they drop down to their lower doses, Rivaroxaban is taken once daily at 20 milligrams, while Apixaban is taken twice daily at 5 milligrams.
Yeah, and this brings us into the realm of pharmacokinetics, specifically peak plasma concentrations. When you administer a drug once a day, you have to give a larger single dose to ensure the medication remains effective throughout the entire 24-hour cycle.
Right, you're front-loading the whole day's supply in one swallow.
Exactly. And that creates a massive initial spike or peak of the drug concentration in the bloodstream shortly after taking the pill. And that's followed by a gradual decline to a trough right before the next dose.
It's a bit of a roller coaster.
It really is. Apixaban, being dosed twice a day, divides that total daily burden. It creates much shallower peaks and less dramatic troughs, resulting in a more stable concentration of the drug over a 24-hour period.
So the hypothesis is that the massive spike from the once-daily Rivaroxaban is crossing some critical biological threshold that just triggers bleeding, particularly in vulnerable tissues.
The editorial specifically points to mucosal tissues, which are highly vascularized and sensitive, and the trial data heavily supports this pharmacokinetic theory.
Because of where the bleeding happened.
Right. Patients in the Rivaroxaban group didn't just experience more bleeding generally, they experienced notably higher rates of specific mucosal bleeds, particularly gastrointestinal bleeding and hematuria.
Wow. Connecting this to the broader picture of medicine, it is a fascinating reminder that the schedule printed on a prescription bottle isn't just an arbitrary instruction.
It really isn't.
We often focus so heavily on the chemical molecule itself when we think about drug development. But the actual physical design of the delivery, the duration of the loading phase, the frequency of the dosing, that profoundly alters human biology and safety outcomes.
It proves that finding the right molecule is only half the battle. Engineering the optimal delivery curve is what actually keeps the patient safe.
So with all this data pointing toward Apixaban, we have to ask the inevitable clinical question. Is Apixaban now the undisputed magic bullet for every single patient on Earth who requires anticoagulation?
In medicine, we must always define the boundaries of our evidence.
Always.
This trial has tremendous strengths. A pragmatic head-to-head design, blinded endpoint adjudication, but we have to strictly box in its limitations so we don't inappropriately generalize the findings.
Okay, let's draw those boundaries. Who does this trial not apply to? First, there's the timeline. The trial only followed patients for 3 months.
Which is important to note.
Yeah, while that covers the critical acute phase of VTE treatment, it doesn't tell us what the safety profile looks like for a patient who needs lifelong anticoagulation.
We also have to look closely at the demographics. Approximately 90% of the participants in the COBRRA trial were white.
Which is a major limitation when we consider pharmacogenomics. We know that different populations can metabolize drugs at different rates based on genetic variations in their liver enzymes.
Absolutely.
If we don't have a truly diverse cohort, we risk missing subtle efficacy or safety signals that might present differently across broader demographic groups.
Furthermore, the investigators deliberately excluded several highly specific, high-risk patient populations.
Like who?
Well, if a patient had cancer-associated thrombosis, severe renal or hepatic dysfunction, or a body weight over 120 kilograms, they were not eligible for this study.
Let's think about that in terms of a mechanical analogy. You wouldn't use a high-performance sports car to tow a heavy boat.
No, you definitely wouldn't.
The sports car might be mechanically perfect and absolutely dominate on the track, but it just wasn't engineered for that specific heavy-duty job.
Great analogy.
This trial proves that Apixaban is a highly reliable, superior tool for standard acute VTE patients. But we absolutely cannot blindly apply the specific safety data to a patient dealing with the complex coagulopathy of active cancer or the altered drug clearance rates of morbid obesity or kidney failure.
Those excluded populations require their own dedicated trials. The data gives us an incredibly sharp tool for the standard VTE presentation, but we have to respect the guardrails the trial designers put in place.
Definitely. Looking back at the whole landscape we've covered today, the shift in clinical understanding is profound. Let's do our 5 take-home points for you to remember. I'll start with number 1.
Go for it.
We started with the observational signal from the JAMA study, that massive 163,000 patient cohort that gave us the first real hint of Apixaban's safety advantage, but was ultimately limited by residual confounding. The RCT was needed to actually change practice.
Right. Point number 2. The COBRRA trial delivered that rigorous proof. It definitively demonstrated that for acute VTE, Apixaban significantly reduces clinically relevant bleeding. That's 3.3% versus 7.1%, and major bleeding events compared to Rivaroxaban.
Point number 3. Recurrent VTE rates were similar numerically. But remember that the trial wasn't statistically powered to prove absolute efficacy equivalence. Still, no obvious loss of clot protection.
Point 4. The bleeding disparity is likely driven by Rivaroxaban's extended 21-day high-dose loading phase and the aggressive peak plasma concentrations caused by its once-daily dosing structure.
And finally, point 5. The takeaway for the medical community is clear. For typical acute VTE patients eligible for either drug, Apixaban has cemented its position as the default first-line oral option, provided we don't overextend that conclusion to those excluded high-risk populations we just talked about.
It is a beautifully clear conclusion, but, hidden within the supplementary data of this trial is a paradox that I find completely fascinating, and it's something I think is worth mulling over.
Oh, I love a good paradox in the data. What did they find?
Because this was a PROB trial designed to reflect real-world behavior, the investigators tracked how well patients actually stuck to their medication schedules.
Okay.
And the data revealed that medication adherence was notably lower in the Apixaban group, about 65.7% compared to the Rivaroxaban group, which maintained a 75.1% adherence rate.
Wait, really? So the patients taking Apixaban were actually worse at remembering to take their pills?
Significantly worse.
And yet Apixaban still resulted in significantly less bleeding and offered similar clot protection. How does a drug perform better when patients are taking it less reliably?
It forces us to think about human behavior intersecting with drug design. Apixaban requires you to take a pill twice a day, which is objectively a higher burden for patients. You have to remember it in the morning and the evening, hence the lower adherence rate.
Right.
Rivaroxaban is just once a day, which is much easier to integrate into a morning routine. But consider the pharmacokinetic buffer of a twice-a-day drug.
If you miss one dose of a twice-a-day pill, you still have the residual medication in your system from the dose you took 12 hours earlier. You don't completely bottom out.
Exactly. When imperfect humans inevitably miss a dose, a twice-a-day regimen might actually be far more forgiving than the high-stakes peaks and deep, vulnerable troughs of a once-a-day pill.
Because if you miss your once-daily Rivaroxaban, you are potentially unprotected for a full 48 hours until your next scheduled dose.
Right. The very thing that makes Apixaban slightly more burdensome to take the twice-daily schedule might inherently provide a safer, more resilient safety net for the messy reality of human behavior.
That is an incredible thought to end on. It proves that evidence-based medicine isn't just about isolating a chemical compound in a sterile lab. It's about understanding how that chemical interacts with the unpredictable, imperfect lives of the patients actually taking it.
It's why we practice medicine and not just read textbooks.
Exactly. Going back to our very first thought today, you don't just want the biggest, heaviest wrench in the toolbox. You want the tool that works harmoniously with the system, stopping the leak without bursting another pipe under the pressure. Thank you so much for taking this deep dive with us today. We hope this exploration helps you see the shifting medical landscape just a little bit clearer. Until next time, keep questioning the data, keep exploring the why behind the medicine, and we'll catch you on the next one.
Thank you for spending your time with PRISM Rounds. If this episode helped you think through the paper or offered something practical for the bedside, I'd be grateful if you'd like, follow/subscribe, and share it with a colleague. It's the simplest way to help this resource reach other busy clinicians and learners. I'm also trying to make the podcast better with every episode. Please leave a comment with what you found most useful, what felt unclear or too long, and what topics or papers you'd like covered next. If there's anything I can do to improve, pacing, structure, level of detail, or audio quality, I genuinely welcome the feedback. Thanks again for listening, and take care. Educational use only. This is not medical advice.